All right, so we left off with looking at the basics of hair follicle infections, going from the fur knuckle to the carbuncle and the different stages what that actually causes. And now we're going into the next one here. This is one that's mainly found in infants, but it's a staphylococcal scalded skin syndrome, or 4S. And this is going to be something that looks like a sunburn at first. There's going to be a lot of redness across the body, but then quickly we'll start moving to the skin getting a wrinkly look to it. A lot of blisters will start to develop. And this is where we start seeing what we have here in the picture, basically looking like the skin is dealing with a severe sunburn. Causative agent, yet again, is Staphylococcus aureus. It's going to be based off that same toxin that it produces called exfoliatin. Just by its name, exfoliatin, it should, immediately trigger in your mind foliation, basically removing dead skin. Here, this particular strain or this particular toxin is what's causing the skin to basically fall off. Luckily, only about 5% of all known staphylococcal strains actually produce this toxin. So it is a very, I wouldn't say rare, but it's pretty close to rare type disease that we see here. There's two types of exfoliatin, and all this is saying. One is coated on the plasmid, which remind yourself, plasmids usually are where the virulence factors are found. However, we do find one on the chromosomal, which suggests to us that over time, the bacteria has decided this is something that's incredibly important to it, so it's actually moved it from the plasmid to its actual genomic material, is all that's really telling us, which is kind of novel compared to what we've seen before. Most things are on the plasmid. So pathogenesis, infection's usually going to be localized, meaning it gets on the skin, some sort of, something happens where the bacteria is starting to get into an adaptation situation. But then the exfoliatin gets into the bloodstream and damages areas of the epidermis, causing that split between the keratinized outer layers, and that's going to cause it to start peeling off. So it's really the toxin, really is the point here, that's causing the skin to come off. We get a lot of fluid loss because the skin's most important job is, one of the more important jobs is prevention of dehydration, keeping the fluids inside. So we get a lot of seepage happening. And also because of all that broken up skin, you're going to risk the secondary infections coming in. Epidemiology is going to be pretty much any age group, but we frequently see it in newborns. It's transmitted typically person to person. And again, just remind yourself over and over again, why is it newborns? Because their immune system isn't quite up to par yet. Treatment and prevention, well, we have to give antibiotics, but then more importantly, we need to get rid of all that dead skin, get rid of any sort of dead material, try to keep the skin and the body as clean as possible. It can be fatal, but usually if we give antibiotics pretty quickly, we can subside the damage and get the mending happening. But again, just imagine if you have something as bad as the one I showed you on the last slide, you definitely probably wouldn't just be sitting at home trying to self-care that. All right, moving to the next one, streptococcal impetigo. Most common form of what's called pyoderma. It's a skin infection characterized by pus, resulting from usually an insect bite, burn, scrape, or other wounds. So this is something that would fall also underneath our wound chapter that we're doing after the exam. But here, this is going to be an example, one that happens when you have already a wound there. So we kind of think about this almost like a secondary infection, or secondary problem. So superficial, meaning it doesn't get much below the skin level. You're going to have inflammation. You'll get these wall blisters form up, almost looking like a cold sore of sorts. And that's going to be replaced by some yellowish coloring. That's the plasma coming out and drying. So it's going to have like this yellowish color to that wound. And that's a good telltale sign. There's going to be very little in terms of pain, which is kind of random, but maybe in the dead center, it might be a little tender, but for the most part, there's not going to be a lot of pain or fever associated with it. And the causative agent here, we're switching to a different one, Streptococcus pyogenes, which we're also going to see showing up elsewhere. But also look at my buddy at the bottom there, Staphylococcus aureus yet again, right? So showing you that this one bacteria can cause lots of different problems depending on where it's found and what virulence factors it's actually carrying with it. Okay, so pathogenesis, there's lots of different strains of staph pyogenes. Some of them are actually already there. They're part of our normal flora. And what we can see there on the second bullet is usually how something like a normal flora becomes opportunistic. We have minor injuries introduce it into the deeper layers of the epidermis, places it's not supposed to be. You get a minor injury, some sort of scrape, some sort of burn, some sort of other injury that now you got an open wound there. The bacteria now is able to get into places it's a little bit deeper than it should be, causing these blisters to form. There's two major virulence factors here. Ones we've also seen before, the M protein, which we've seen at the beginning of this chapter, and hyaluronic acid capsule. So this is a capsule. You don't need to know it's hyaluronic, but essentially it's a capsule. Remember, capsules are camouflage for the bacteria. And so having that camouflage as well as the M protein helps it fight off the immune system, allowing it to progress. And then we also have the same problem we've seen earlier with one of the other diseases. We have risk of post-streptococcal sequelae, particularly in the kidneys. And again, when you get the inflammation in the kidneys, you could potentially start getting damage, sepsis and damage to the kidneys and ultimately shutdown, which then is a bad path to go down. So epidemiology, poor, most common among poor children. Again, when we use that term poor, we're really talking about socioeconomic environments. Are they living in squalor? Are they living in a non-hygienic home? One that maybe lots of trash and indigenous people. We're not necessarily saying, oh well, they're barely making it or they're working paycheck to paycheck. That's not what we're talking about here. We're talking about children that truly are, as Shan pointed out, indigent. Is usually where we're seeing this from, especially in hot, humid areas. Why is that important? Because this bacteria, is going to be one that propagates very well in humid areas and in hot areas where you got plenty of moisture as well as heat. So these two things going together, unfortunately, is usually where we see this disease. Person-to-person contact. So again, somebody that may not be washing their hands, it's helping try to treat the wound or something like this. Could also move it from one person to another. Insects can carry the bacteria because what do insects do? They land on your skin, they go land on somebody else. They're transferring that bacteria back and forth. And fomites. Remember, fomites are just any inanimate object. So somebody touches there's the wound or a gout, and they go touch this door handle, walk out. You go behind them, touch that door handle. It's now on your hand. Patients often become throat and nasal carriers. So in this case, again, Pyogenes is a part of the normal microbiota. And so it's not surprising that we can also find it on the patient months later, years later, as part of their normal microbiota also. So treatment, luckily, Pyogenes is a wuss bacteria. It's easily wiped out still by penicillin and erythromycin. So it doesn't require much more than a Z-Pak. To get it to clear, but we have to get that patient to take it, come to the doctor. Again, if you're dealing with indigent, they're probably not going to have access to healthcare or may second guess going to healthcare. Wound cleaning, antiseptics. Again, antiseptics are just things that you use to clean the wound. You can buy over the counter. Avoiding contact limits the spread, keeping the skin clean, and avoiding sharing personal items. Now, if you grew up in an only home or it's just you and your significant other, whatever it might be, you're probably sitting on who shares. Well, dorm settings, we're at barracks in a military establishment, large families, you may end up sharing a lot of things. And so this becomes a major point for actually spreading of disease is through sharing personal items, whether it be a razor or toothbrush or something. A lot of this just makes me gross out anyways, but at the end of the day, people do it, and this is where we see some of the spread happening. All right, next one is another insect-borne disease. You may look at the name and go, well, it's nothing I need to worry about because we live in Louisiana, but it is something we're actually seeing spreading away from its normal area. So Rocky Mountain spotted fever. Obviously discovered in Rocky Mountains, right? Because of its name. Again, when you look at the signs and symptoms, I want you to appreciate that they're usually pretty benign. Sudden headache, pain in muscles and joints, maybe a small fever. Well, if you've been out hiking all day, sure, your joints are going to be and muscles may be a little, worn out. You may have a little headache, and you go, oh, no big deal. Well, then you're going to start getting these rashes forming and see how they're basically all over the skin. We just have obviously for patient protection, we're not showing any facials here, but here you have the feet, but this would be all over the body, right? You end up with this big rash that forms all over. And what we have problematic then is if you have red, that means there's blood there, right? So it's only going to be a matter of time before these rashes end up popping or actually breaking through the skin, and you start getting blood leakage around the palms, wrists, ankles, anywhere where there's those that rash that form. And you may also end up getting some other bleeding from other sides, the tear ducts, the nasal, mouth areas, anywhere where it's easily accessible. You might start seeing some blood come through there. And then, obviously, this is a major systemic problem since it's throughout the entire body, so that we start seeing organ damage happening anywhere from the heart to the kidneys, causing that blood pressure drop. Again, nothing we haven't seen before, right? When we end up having that dilation of the capillaries and the other vessels, then you're going to end up having blood pressure drop, and that can lead to shock and ultimately death. So causative agent, it's kind of a fun name, rickettsia. And so it's basically got two of the same name. It's a gram-negative, non-modal. So this tells us that it isn't able to move. It doesn't have a flagella. Coccobacilli. This tells us that it has kind of a round, almost like an egg shape to it. It's not truly a coccus, and it's not truly a bacillus. It's kind of in between. And here's the part that's kind of interesting about them: an obligate intracellular bacteria. That tells us that it has to live inside our cells. That's weird for a bacteria. That's usually something we reserve to viruses. They're difficult to grow in culture, so this limits the ability of how we're able to study it. So what we have to do in order to identify that somebody has been infected with rickettsia is do it by skin biopsies, utilizing some of the molecular tags that we know that are found on the surface of that bacteria, and verifying it through immunofluorescence, essentially the stuff we learned about in Chapter 3 using the fluorescent microscopes. Pathogenesis, here's how we get it, transmitted by tick bite. Ticks are annoying. If you haven't ever been bit by a tick, don't allow it to happen, they suck. So 4 to 10 hours of feeding, so essentially you get bit, you don't know you're bit most of the time because they use a numbing agent when they bite you, so you don't even recognize you've been bit half the time. And then they can sit there and feed off of you for as long as it takes. They're very, very small when they first start out, and they can engorge up to 6, 7, 8 times their size by basically sucking blood out of you. While they're doing that, they're using the blood to help feed their pregnancy usually. And while they're sucking blood out of you, they're also shooting out that numbing agent so you don't recognize you're being sucked on. And when that happens, the bacteria is actually getting pushed out with that numbing agent out of the tick right into your bloodstream. Thus, how it's able to go so systemic so quickly, because it's just basically injected. That bacteria is injected straight into your bloodstream. Pathogenesis: the bacteria coats themselves with our actin. So remember, actin is part of our cytoskeleton as well as other organisms, but we have actin. And so what they're doing is they're essentially camouflaging themselves to look like us, look like our cells, look like self. And they're able to move from host to host, or from host cell to host cell, because they are obligate intracellular. They're able to move back and forth by having that coating of actin. It allows them to move back and forth between the cells pretty easily. When they do move out of one cell to the other, that ruptures that cell, causing it to break, causing those rickettsia, those bacteria, to basically release into the bloodstream. And they'll just keep moving to the next the bacteria will keep moving to the next cell, just like a virus. It acts just like a virus. So once we end up having that damage, again, we have the inflammatory reactions going to lead to some clotting in the blood vessels because, again, the immune system's trying to block it off. And unfortunately, blocking off a bacteria that's inside the blood vessels is never a good idea, because you're going to end up getting the clotting. And that produces those small areas of skin rash and eventual necrosis, uncontrolled cell death that happens there. If we get that clotting to continue on, then like we pointed out before, you get clotting in the kidneys, you start shutting down kidneys, start causing problems there. Getting in the heart, always problematic. Even if we can clear the infection, the damage that's done to the kidney and heart can be lifelong. And so this is always, part of the problem too. Epidemiology, sporadic distribution. Zoonosis is maintained in species of ticks as well as the mammals that they bite. So it could be deer, it could be elk, whatever it might be. Keeps that life cycle of rickettsia going. We're an accidental host. That's why we have such a major reaction to getting rickettsia, is because we're an accidental host, and so getting it into us causes a major inflammation. Where if it just stayed in the ticks and the deer and elk, whatnot, it may not cause as big of a deal. Here you can see anywhere in green, they had 0 cases. This is broke down by county, or here in Louisiana by parish. 1 to 14 cases is the blue, and 15 or better cases in that given year is orange. And what we can see here is that, yes, there is a lot of it, here in Oklahoma, Denver, or Oklahoma, Colorado area, Kansas. But right here would be the Rocky Mountains. That's just happened to be where it's discovered. Notice the majority of it is to the east, all the way out to North Carolina and back. Yeah, so anywhere that we have ticks, essentially, we're going to have rickettsia. And so it only takes one of us going on a vacation and then getting a tick bite to come back here and have it show up in the hospitals or clinics here. So treatment, doxycycline and chloramphenicol, given early to try to prevent that organ damage. We're trying to stop it from getting organ damage. Remember, chloramphenicol is going to be something we're not going to use very often because it does have that aplastic anemia side effect for some people. So we do use it limitedly, but in this case, it is an important time to use it. Case fatality without treatment is about 20%. So you have about 1 in 5 chance of dying if you don't get treated. Even with treatment, we can get it below 5%, but there's always a chance we can lose people because of the fact that it is so systemic and gets into the blood vessels. No vaccine, but preventative measures can limit. Of course, if you're an outdoors person, you already know how to limit ticks, but if you're not, typically if you go out hiking in the woods, you want to wear long socks, jeans, things like this. Minimize any chance that the tick has to touch your skin, because most of the time they're going to be down at ground level. So that's what it's saying here for preventative measures. Okay, another one that's a nasty little skin disease, Lyme disease, another tick-borne one. First recognized in the 70s in a little town called Lyme, Connecticut, which is where it got its name from. It's not spelled the same as the fruit, right? That's L-I-M-E. This is L-Y-M-E. Causative agent was identified in 1982 by a person named Willy Burgdorfer, which is where the bacteria gets its name. So here the bacterial name is Borrelia burgdorferi. So again, named after the person that discovered it. We get about 25,000 cases a year. This is one of the most common vector-borne diseases in the United States. Vector-borne meaning it comes from mosquito, tick, flea, some sort of insect, right? So in this case, this is the biggest one that we see in people. And there's going to be 3 stages. Most individuals are going to end up asymptomatic, but occasionally we'll see people switch out and go to one of the other more serious stages that gives this particular disease such a scary name. Borrelia is going to be large gram-negative, microaerophilic. All that means, again, don't get lost in the nomenclature. Microaerophilic means that it likes low levels of oxygen, doesn't really care to be in atmospheric oxygen. But the more important part is it's a spirochete. This is the first time we've seen one of these. We talked about them in chapter 3, but spirochetes are different than the coccus that are spherical, bacilli that are rod-shaped. Spirochetes have a corkscrew shape to them. So what they do is they actually burrow, using that corkscrew shape, they burrow right into the muscle tissue, which makes it incredibly difficult for us to clear these infections in people that end up with Lyme disease. So signs and symptoms. Well, you get bit by a tick, and you may pull the tick out. It may have fallen out on its own, but you recognize you have a tick bite. So that early localized infection is going to be due to the bite that damages skin. But one of the things that tells us that early signs that are going to tell us that maybe that person has Lyme disease is that we get this bullseye rash. You end up with a very dark red spot where the tick had bit you, and then there'll be some clearance, and then you may have another red circle or even another red circle that goes around that from the actual tick bite area. Weeks after the tick bite, we might end up with inflamed lymph nodes, again, telling us that the immune system is trying to fight something off. But at this point, you don't really have any other signs and symptoms. Then you may get flu-like symptoms. You may end up feeling like you're very sick. Again, most people aren't going to recognize or aren't even going to relate that it's due to that tick bite, right? Because this is weeks later. So they may think, oh, I just got the flu or I got some sort of bad cold. They're not going to relate it to being due to that tick bite, especially if they haven't got treated yet. Early disseminated infection. This means that the infection has gone septic, more or less, or moved on. And this could take up to a couple months later. Nervous system becomes affected. You start getting electrical conduction in the heart impaired, so the heart starts getting abnormal beating. You might end up with other physical impairments. Maybe you're not able to move your muscles the way you think you should. Again, you're going to have some nervous system breakdowns happening. Dizzy spells, fainting, paralysis of the face. The whole face just kind of goes a paralysis. Severe headaches, difficulty concentrating. These two also related to the nervous system shutdown, right? Difficulty concentrating, severe headaches. Then it's going to lead into emotional instability, right? Just imagine how, even if you are within your own mind, having all this stuff happening, I'm sure you're not going to be a very pleasant person. But for those that have caused it to, allowed it to go completely to the other side where it's actually affecting their ability to handle their emotions because of nervous system breakdown. Fatigue, impairment of nerves of legs and arms. So we start seeing people become completely paralyzed. Late persistent infection, 6 months after that skin rash that we initially started with, so almost half a year later. Joint pain, swelling appear, slowly disappear over the years, and you'll end up with chronic nervous system impairments in some people. My great aunt just passed away last year. She had Lyme disease for 35 years. She got bit by a tick out in her orchard, and she lived with it for 35 years. Did she have, sequelae? Yeah. But it wasn't enough to actually impair her from living on her own. She lived on her own all the way until she died at 88. But again, she was fighting Lyme disease. She had to take daily pills to try to minimize or help take care of any of the chronic damage. So it's not a terrible disease per se. You can live with it, but it is something that has to be monitored and taken care of over the years, especially if it ends up going all the way to late persistent.
What is the infection from ticks that causes you to be allergic to different meats?
That's when your immune system starts going goofy, and an autoimmune disease essentially, because it's not that the tick is giving you something that's going to cause you to be allergic to meats. It's causing your immune system is acting up, and sometimes it bypasses the normal checks and balances we talked about. Then you might end up with an allergy to meat. I've seen that before. Yeah, I personally not seen it, but I've seen the stories that you're talking about. All right, so spirochetes. This is also what makes it so difficult to treat. It's a spirochete. Look at that goofy thing. It almost looks like a little worm, huh? But that's a microscopic picture. They're introduced to the skin by the infected tick. So the same way, it's putting that numbing agent into you as it's sucking blood. So that circular is actually pushing the spirochete out. And it's able to multiply and migrate in a circular fashion. So that's where we end up with that bullseye look to it. It is a gram-negative, so we are going to get the LPS being involved. Remember, LPS is the only endotoxin. So the immune system really hates seeing LPS. And so here's another way where we start seeing some of that early breakdown. It gets into the bloodstream. This is when we call it disseminated. So it's left the localized site and got into the bloodstream. So basically connecting early disseminated infection. This means that very first couple days after the spirochete is moved away from the localized area to the actual blood vessels themselves. Immune system responds, disease progresses through those 3 stages, and humans, again, are an accidental host. That's why we end up having such a major inflammatory event. in diseases that we are part of the cycle of life for that particular pathogen, a lot of times we end up having minor to no symptoms, asymptomatic, because it's just something that we have learned to live with and evolve with for millennia. Where something like Lyme disease, rocky spotted fever, things that we haven't evolved with, we end up being an accidental host and we end up having these major inflammatory reactions. Again, here you can look at the picture. The biggest problems that we see with Lyme disease is going to be in the Northeast as well as in Wisconsin, Minnesota area. So much so that they actually are baiting wild animals that are part of the normal life cycle to to try to thin the herds, whether it be deer or raccoons. I think it's deer in Minnesota, Wisconsin, and raccoons over here in the Northeast, where they will, it's also with rabies too, but they're ultimately trying to minimize the damage by having those populations be out there, increasing the number of ticks that are available too. All right, epidemiology here. The tick name, Zoetes scapularis. There's anytime it has an IXODES, that's a tick. So there's multiple different species of tick. That's just genus they fall under. So small that 2/3 of Lyme disease patients don't even remember that they got bit by a tick. So just to show you how small these ticks really are. Most people don't even recognize they got bit. And antibiotics are effective if we catch it early. So somebody's like, oh my God, I got a bullseye. I got bit by a tick yesterday. We might be able to actually clear the infection before it even has a chance to establish itself. But that's going to be very, very early. Prolonged treatment with ampicillin and ceftriaxone is going to be what we actually go moving forward. This will be something that they'll have to be on for multiple months, if not a year or better, depending on their state. Preventative measures are going to be the same because we're just trying to keep those ticks away, right? If we can keep the ticks off of us, there's no chance in heck that you could ever catch Lyme disease or Rocky Mountain spotted fever. These are only going to be based off of a tick bite. Luckily, unlike a mosquito, we can prevent ticks, right? Mosquitoes sometimes, no matter how much you spray on, they still bite you. We all know this. Here ticks is a lot easier to prevent. All right, now getting to one that we just had our little extra credit on, whether you did it or not. We did have that little paper I sent out on chickenpox, known as varicella. As its proper name, chickenpox is its lay name. And these are viruses, so we're switching gears, right? So when you're studying, make sure you pay attention up here. We're switching gears. Now we're away from bacteria. We're going into viruses. And so varicella is the first virus we're looking at. And we've all seen, whether we live through it or recognize the conditions that it causes. We know that it causes this rash-like look to it. Begins as small red spots. We call those macules. So the little red spots are macules. It progresses into bumps. So what's the difference between a macule and a papule? Well, if you can touch it, it's flat. It's a macule typically. If it has a bump out to it, it's a papule. Then you get the blisters, which are going to be the vesicles. Lesions can appear at different times depending on the person. Can occur anywhere in the body. So you can have head to toe. It may just be on the buttocks or legs, or it could be on the chest, or it could be completely over the body. Everybody's immune system responds a little bit differently. And if they are itchy, we have this term here, pruritic, which just says that it's itchy. Again, nomenclature that I don't necessarily ask you questions on, but since most of you want to get into these fields, at least recognizing that there's different names besides the layman names that we use for some of these basic terminology. So what happens here is that, especially since it happens in children, one of the biggest fears that we have for children is that they constantly are scratching themselves, right? You may do it with mosquito bites, whatever. You start scratching them, you end up opening them. You end up opening up a chance for secondary infections. Going right back to where we talked about starting today with pyogens and aureus, essentially getting into areas that they shouldn't be in. Getting into deeper areas, and then we start having secondary bacterial infections we have to start being concerned with. Now, as we've seen in the extra credit assignment, the more severe part, group that we have to worry about are adults. Of about the 20% of adults that get chickenpox at that age, they actually develop pneumonia and lead to other problems down the road with those secondary infections. Damage the lung, heart, kidneys, liver, and brain of immunocompromised individuals, and death happens about 1/5 of all adults that end up getting it. Major threat to babies. Again, if they get it very early before their immune system is activated, we have about a 1/3 chance of losing that child that develops chickenpox. And so what we worry about mainly, it's not that the infant's going to get it very early. It's going to be if they get it from mom, if mom already has an active form of chickenpox. So babies born to mothers who had chickenpox early in pregnancy may develop what's called congenital varicella syndrome. So we do, check and monitor these things throughout the pregnancy. And if you haven't had chickenpox and you're pregnant, then we usually will request the vaccine, that you take the vaccine, but we can't force you. But what we're worried about is that you end up passing on congenital varicella syndrome, which essentially is going to be a death sentence to a child. Now, we probably all know this. I think it's reactivated later in life. We call it shingles, right? So it's just a different variation, but it's the same virus. This virus ends up going latent, which means it gets into our nervous system and just it hides and goes to sleep. So there's no way to know when it's ever going to come out of latency to develop shingles in somebody. Some people will never develop shingles. Others will get it very early in life in their 40s. Others may not get it till their 70s and 80s. There's no real way to actually gauge or to forecast when shingles may show up. Reyes syndrome is something that is characterized by liver and brain damage, and this is something that we see on the back of Tylenol. So any acetaminophen, aspirin type pills, not Bayer or not Advil, which is ibuprofen. This is just strictly acetaminophen. We see this as possibly a kind of like an autoimmune type disease. The acetaminophen drives the immune response to develop what's called Reyes syndrome, which is it's going to cause this liver and brain damage. It's a real loose connection, but it is enough of a connection that they do put it on the back of the bottles now as a warning sign. So causative agent, varicella zoster virus, or VZV. It's a herpes family virus, so we haven't got into herpes yet, but herpes is HSV1 and 2, 1 being the cold sores, 2 being the sexually transmitted herpes. Well, chickenpox is in the same family as those two viruses. Enters through respiratory tract, so this is passed person to person through breathing, and respiratory droplets, as we see in chapter 21, and then travels to the skin through the bloodstream. And once it gets to the skin, it's going to start reproducing the virus there in the epithelial cells, and we'll end up having a lot of immune system things happening here, where we get the multinucleated giant cells, those macrophages showing up, causing trying to clear this infection. We'll start seeing the cells swell, lyse, and the virus entering the nervous system. So this is just what the viruses do anyways, right? They swell the cell up, they burst the cell, the viruses then move off to the next ones. Sometimes the virus can then enter the nerve and travel to the ganglia near the spine, and that's where it goes senescent, where it goes quiet, and it can stay there forever. Shingles coincides with the decline of the cell-mediated immunity. So why do we get it as older adults? Same reason we worry about infants getting it. Your immune system is not quite operating well. So as the cell-mediated immunity starts going down, it may be involved in holding that virus in the nervous system. But as cell-mediated starts weaning, then the virus pops back out and reestablishes into a shingles, and that can always add problems, especially in elderly. So notifiable disease, this is one of the first times we see this term. Notifiable disease means that if somebody comes into your clinic, your hospital, your doctor's office and has this disease, you must tell the CDC, you must tell the State Department of Health that you have had a certain case. And so we're going to see this more as we go forward. Measles, mumps, pertussis, all these are notifiable diseases too. So we'll see these popping up more and more. 1990s, about 4 million cases a year. As you learned in the extra credit, the varicella vaccine came online in 1995. So up until 1995, we had about 4 million cases a year, which resulted in about 10,000 hospitalizations. So you figure that's a pretty low number. It's actually only a quarter of 1%, which end up in the hospital. And then we'd actually end up only with about 100, 150 of those end up with death. So in the grand scheme of things, when we actually look at that, it's not a terribly serious disease, but it is something that we do have to keep an eye on, right? So this is a problem. A decade after the vaccine was introduced, fewer than 500,000 cases and only about 8 deaths per year, usually from unvaccinated individuals. This is going to be transmitted, as we already talked about, respiratory secretions, also skin lesions. So touching somebody that has an open wound, at their rash sites is actually going to have live virus in it, can transfer. Most cases in the winter and the spring months, usually when you're in close proximity, inside. Also during the school month seasons, right? So anytime that you're in groups, those respiratory diseases are much easier to spread. Humans are the only reservoir, which makes it a beautiful target for a vaccine and eradication. This is one of the very first rules we look for when we determine if it is something we can truly eradicate. Something like Lyme disease and Rocky Mountain spotted fever, rolling around in ticks. There's no way in the world we could ever eradicate those diseases, because that means we'd have to eradicate all the ticks, all the other mammals. But when we are the only reservoir, it makes it a good target. It's one of the first things that we look for. Highly contagious, incubation period about 2 weeks. So again, you can walk around for a couple weeks. If you did get a chance to read the story that I sent out, you'll recognize that the guy was sitting there, the dad was sitting there playing with his kid. Oh, she's sick and I'm fine. Well, idiot. It's 2 week incubation period, right? So during that time, I'm sure he was fully incubated, but he wasn't showing signs and symptoms yet, because it takes upwards of 2 weeks. Ability of the virus to form latent infection. All this is saying is that it's able to go into senescence, stay quiet, for decades, however long it is, and can reappear in shingles in about 1/3 of individuals. So anybody that's had chickenpox already, anybody that's had the vaccine and never had it, we're all potentially susceptible to shingles, because we don't know how long the vaccine is good for, because it just came out not very long ago. 20 years ago. So we don't have any long-term projection studies of, memory cells in terms of how long they last after this vaccine. And that's why there is a adult booster that's now suggested by the CDC to try to help boost up those memory cells to maximize your chance of not getting it. For those of us that have already had the virus, there is also a CDC recommendation for a vaccine just to help boost up the memory cells too. So treatment, these are two, medicines that came out here just recently. I wouldn't say recently, but maybe in the last 20 years or so. Acyclovir and famciclovir. These are two very effective antiviral drugs used not only for chickenpox, but also for people that have genital herpes and cold sores. These three, can be effectively treated with acyclovir, and lesser extent its cousin, famciclovir. And we have the vaccine, which is an attenuated chickenpox. Remember what attenuated means? Attenuated means it's been dumbed down. It's still live, right? So this is something we do have to do the pre-questionnaires to people that get the chickenpox vaccine to make sure that they are, healthy. This is why before you get a vaccine, I ask you, have you been sick in the last couple days? We don't want to give you a vaccine that's attenuated if you have already been fighting something, if your immune system is already kind of beat up. We need you to be healthy, because there's always that very, very small chance in some people that they could actually develop chickenpox from the vaccine because it's an attenuated strain. Now, flu, not so much, right? Flu is subunits. It's actually just pieces and parts. Sometimes we use these attenuated strands because they give us a better response in the immune system versus taking pieces and parts of it. Shingles vaccine is available for 60 years and older. Essentially, it's the same vaccine. We just suggest it to older adults. Much higher dose essentially reduces the risk by about 50% in adults that have already had chickenpox before. Immunocompromised individuals are going to get the severe, which could end up being very similar to what the person in the story had. Partial protection, we can do passive immunization with basically antibodies in high concentrations against the virus. So somebody that is immunocompromised ends up with chickenpox. Here's what we can do for them. We can basically give them antibody treatments to try to boost up what their immune system should be doing on its own, but we're helping it by giving it a boost from a donor essentially, and try to put those antibodies into their system.
So if you get the shingles vaccine, does that mean you don't have to get the chickenpox adult booster?
It's the same virus, it's the same vaccine,
Right.
but the shingles one is like a little bit bigger.
So it really wouldn't matter if you got the shingles or.
It just depends on what age you end up getting the vaccine. They may give you a stronger dose versus the normal dose. All right, so now we're going into our second of the notifiable diseases, so measles. Now this is a little bit different. There are cohorts of people like myself that have had chickenpox before. Is there anybody here who's ever had measles? One or two? No, right? So measles is something that we all just kind of assume because the vaccine's been around since the 60s. We kind of assume that this is a disease that doesn't exist anymore, but we are very wrong about that. And so here, another reason why it is able to propagate. I want you to just kind of pay attention to the fact that all the signs and symptoms are so boring, right? Fever, runny nose, cough, swollen red, weepy eyes. And are you immediately going to go, oh, I got measles and run to the hospital? No, right? So this allows it to continue on in the population. What we end up having then about a week later is you end up with something that's similar to chickenpox, but not the lesions that chickenpox brings per se. We end up with a very fine red rash that appears within about a week. And that's one of the biggest signs that we have a problem, right? This would definitely cause you to go into the doc, hopefully. But then, because of all this rash happening here, and remember the rash is simply the immune system response to the virus, that's going to cause the chances of secondary infections, just like every other disease we've looked at so far, because all these skin diseases, right, that's the whole chapter, is skin diseases. We end up with some sort of compromising situation of the skin. It's always going to allow secondary diseases to come in. In about 5% of cases, we get viral pneumonia. Nothing we really concern ourselves with too much. It's always the next one here that ends up being the problem. 1 in 1,000 cases will end up with encephalitis, which is basically swelling, internal swelling, and so that's problematic. And then for some people, they'll end up upwards of a decade later after having measles, they'll end up with subacute sclerosing encephalitis. Which is a pancreas. So essentially we get swelling of the pancreas, and that could be a major problem too for those individuals down the road. Otherwise, pregnancy is a big problem. If you end up getting measles while you're pregnant, it can cause risk of miscarriage, premature labor, low birth weight, essentially preemies, can be born to mothers that have active measles infection. So again, when you look at it, you say, well, not a big deal per se, unless you're pregnant, or you end up with encephalitis of the pancreas. But, it's really something that most people, including our grandparents and great-grandparents, they just got and cleared just like chickenpox, right? It was nothing that you even worried about. The reason why we built the vaccine is because of these very small cases right here, trying to prevent this. So causative agent, rubeola virus, paramyxo family. Again, I don't ask you questions about matching family and virus, but you will notice as we continue moving forward in the last few chapters we have left of the semester that paramyxo is a pretty popular family of viruses that cause disease in humans. So just kind of focus on those things just to see the connections. On its envelope, it has the same protein that flu has, hemagglutinin. So we can look at that as a tag, in terms of if somebody's sick, because again, viruses we can't look at underneath the microscope. We have to actually diagnose through signs and symptoms, as well as sending it down to pathology, med tech labs, where they're tagging, looking for these little pieces and parts that help us differentiate these different viruses. Acquired through respiratory, so even though it's a skin disease, you're still breathing in the air, somebody that's infected, measles. Spreads in lymphatic tissue and then all parts of the body. Again, same reason why we have that rash everywhere. As already pointed out, rashes results from the immune system's response to the skin. And we end up with what's called these Koplik spots on the mucous membranes. And these Koplik spots are going to be these little white, basically non-symmetrical little spots that we can see on the skin when we look into the mucous membrane area. So looking up the nose or looking to the back of the throat, we see these little white Koplik spots. That's a telltale sign. So somebody comes in with fever, some rash. How do we know if it's chickenpox or measles? Well, hopefully we're going to know if they had their vaccine for measles, and we're probably not thinking it's chickenpox. Or we're probably thinking it is chickenpox. But here, if it's somebody we know has never had a vaccine in their life, coming in, trying to determine what type of rash they have, this Koplik spots is a good one to look at to be a defining feature of measles. Suppresses immunity, damages the intestinal epithelial. We get lots of diarrhea in measles patients because their epithelial layers of their intestines are being beat up. And we get about 1 death per 1,000 cases of measles. So epidemiology, again, humans are the only natural host. So again, why we have been so successful with the vaccine strategy. If we can vaccinate people to the point where they never get the disease, then there's no chance the disease can actually spread. So we're only harboring it in those individuals that do not get the vaccine. Prior to vaccine, probably less than 1% of the global population escaped infection because it was so contagious, just like chickenpox. You just got it. It was part of the knowledge of a child going through childhood. They were going to get measles, they were going to get chickenpox, they were going to get all these other diseases we're going to see as we keep moving forward. But because of the vaccine, it's no longer an epidemic in the Western Hemisphere. Epidemic. We still got it, but it's just not something that we have to worry about it passing from person to person and everybody getting sick. Worldwide, though, we saw about 750,000 children being infected every year and dying. So this is something that if you do concern yourself with global affairs, you may want to think about, maybe you want to work with Nurses Without Borders or Peace Corps or Doctors Without Borders. If you're trying to go get your MD, this is something that is a very serious situation in other countries. There's no antiviral, so that means there's no treatment for somebody that is sick. We can only give them palliative care, but we do have our amazing vaccine that has been very successful. It's another attenuated vaccine, so this is why we do not give it until about 6 months, because it is an active virus. And so we got to make sure that child's immune system is up online. 1980, worldwide incidence of about 100 million with about 5 million deaths per year in that year. Once we introduced the vaccination programs to be basically required, yes, the vaccine was developed about a decade before that, but public health policy, CDC, government, getting involved and saying, okay, you have to get this in order to go to school or the other things that we asked, has caused the incidence of measles to drop significantly. But we are seeing it on the rise here in the last few years, in the last decade or so, from all the anti-vaxxer movement, where we're now seeing about 100 some cases. Actually, I think it's even higher than that. These are a couple-year-old slides. We're actually seeing measles popping up in quite a few different places. Up in Minnesota, Wisconsin area, we're seeing it quite a bit, as well as over in California. Any place where we got large cohorts of immigrants, as well as people that may be living out in boondock areas where they only bounce ideas off of their neighbors and their family and friends. And so if you get an entire cohort of people going, oh yeah, vaccines are bad, well, they're all going to believe that. They believe their own nonsense, and that allows these diseases will pop up in these areas. Next one, rubella, German measles. So it's just a different variation of the same disease. But here, this was one that you got as a kid. It was just called the 3-day measles. It looked very similar to measles. You got the same type of rash, but it only lasted a couple days. And so this was a way that we could differentiate the two different types. But this was another disease that you just basically got as a kid, more or less. Slight fever, mild cold, enlarged lymph nodes behind the ears and back of the neck, so you can feel the lymph nodes back here being a little bit swollen, and a faint rash after about a day. So again, pretty minor. It's always that small cohort of patients that we're more worried about. There's no Koplik spots, so that's a way we can tell the difference between measles and German measles, is those Koplik spots are not there in the German measles. If you get it as an adult, it's always worse, right? Same thing with measles, same thing with chicken pox. All these diseases are much worse as an adult. You end up getting joint pain for upwards to a month. Other symptoms may only last a few days. And again, there's always a threat to developing fetus. The placenta is very good at protecting the child, but there's especially viruses, they're able to jump over that placenta pretty easily. Cause of agent here is just another virus called rubella. It's part of a different family, the toga virus. And yeah, I got its name because of the look that they have. They thought it was like a toga party the viruses were going on. So it actually got its name toga viruses because the look of the viruses under the microscope. Easily cultivated, which helped us understand how it actually works. Respiratory tract yet again. So nothing, even though there's a lot of words in this chapter, the idea behind most of these viruses so far, they're all the same. It's all respiratory passage, but then manifests itself as a skin disease. Rash and joint symptoms early in pregnancy, they can cross the placenta, infect the fetus. Once that happens, that poor fetus is a smorgasbord for that virus. It has no immune system, has no way to protect itself. So all this damage that happens to the developing fetus is because that virus jumped across the placenta. The placenta is the shield protecting the child, and now there's nothing protecting it. It's basically able to do what it wants with the child. So we end up having the entire fetus, every single cell is susceptible. There's no protection. And most of them are going to cause all kinds of patterns of abnormalities, congenital problems with the child, developmental issues if they're able to survive. A lot of times they're going to die pretty early. Yeah, you see here, eye defects, brain damage, deafness, heart defects, low weight, all these terrible things. So again, getting it normal route as a kid, not a big deal. This is what we're protecting against, right? We're protecting against pregnant mothers. So again, humans are the only host, highly contagious, but over 40% of people end up being asymptomatic because it is a minor to what they call 3-day measles. So in this case, it's not surprising that a lot of people are going to be asymptomatic when they get it. This is going to be the same vaccine, so measles, mumps, rubella, right? Rubella is the German measles. So here's just part of that same vaccine strategy. And when the vaccine was distributed, we started seeing much lower incidence as you would expect. 1964, right before we started using widespread vaccine, we ended up having about 30,000 cases of congenital rubella syndrome. And what happens with these people is we call it the rubella bulge. These poor kids got German measles when they were very young. Part of the chronic problem that they end up having from it after the virus is gone, not caused, but the damage that was left, is they have a lot of hearing loss. 1960s, we didn't really have a strong understanding of childhood hearing and how these things could be lost. And so kids that end up going to school and maybe sitting in the back, maybe even sitting in the middle, they couldn't hear what the teacher was saying. And they end up having bad grades, they end up started failing. And so we had this entire cohort that we were able to recognize of children that had been infected with German measles that ended up having hearing loss, that ended up doing worse in school. And that started changing some of the ways that we monitor and test children's hearing and sight and whatnot, even in the school systems, to try to recognize this. No treatment. Again, it's a virus, really hard to treat. We do have that attenuated vaccine as part of the MMR that you get now 3 times. You get one at 6 months, you get one at 5-6 years, and then you get one as an adult. So there's actually an adult booster now that they recommend even with MMR. Produces long-lasting immunity and not given to pregnant women because of the chance that it is an attenuated vaccine. So we're going to minimize the chances of even potentially giving it to the mother. So we ask her to just be cautious who she's around and minimizing contact with people. All right, so other rashes of childhood. It used to be 7, and it was just part of the process at year 6. It used to be just the process of life, right? You just go through the 6 diseases as a kid, and you just kind of check them off with your family doctor and say, okay, well, little Clinton already had 1, 2, 3, 4, and now we're going to go to go into the 5th one. That was when I was little, right? See what you're doing. All right. Rubiola is number 1. Scarlet fever is 2. Rubella, Duke's disease. This one's actually still called 5th disease. So my child actually went into the doc and they're like, oh yeah, it's 5th disease, and it was only because of teaching this over and over again. I'm like, oh yeah, I know what that is. But again, and then 6-1 roseola. All these are just rashes that they develop that are viral related. And so, like I said, you just basically check them off as you went through. Now, a couple of these are vaccine preventable, so we don't necessarily see them as much. But just to go ahead and just point out the fact that it was pretty common to just get these and move on with life as a child. So here's 5th disease, or Erythema infectiosum. Sounds like something in Harry Potter. It occurs in both children and adults. So this is something you can pass on from child to adult. But not very serious. Minor, fever, malaise. Malaise just means not feeling all that great. You wake up in the morning, you feel cruddy. That's malaise. Head and muscle aches. Again, nothing that's going to have you running off to the doctor. And we get that redness on the cheeks. It looks like, as the book explained, it looks like you've been slapped. So that, basically, flat, flushed redness. And spreads in a lacy pattern elsewhere in the body. So you can see here, it looks like a lot of white and red there in the hands. That's showing that laciness, where on the face, it's almost all red. And it may come and go. You'll have it go away for a day or two and come back for a couple days, and that'll go back and forth for a couple weeks while the immune system's fighting it off. But again, adults, it's never fun to have any of these diseases as an adult. You end up with a lot of joint pains, a lot of other problems that can come with it. This one's caused by a virus called parvovirus B19. Again, when you're studying, focus on the name of the virus and its causative agent. Don't worry about the families and what they look like. Unless they're unique, like spirochete, that's a bacteria that causes Lyme disease. It's a very unique shape to it, so make sure you understand the shape of that one. But here, these are just a lot of information that's a little over the top in terms of what you need to know for the test. 10% of pregnant women are going to develop spontaneous abortion that end up with 5th disease. So yet again, it's a problem for pregnancy. And it's also very common in children 6 months to 3 years old. You may end up with a very high fever. In children, they can, especially small kids, they can handle a little bit higher fever. They actually usually run with a little bit higher temperature than your standard 98.6. So 105, that's scary. Definitely scary. You start getting into convulsions, things like this. So this is much higher than your normal temps that you'd see in a child. And otherwise, the child is not going to be ill at all. They're going to have some rash, fever, but nothing else. You're not going to have a cold or cough, sneezing, anything like this. So kind of a strange manifestation of the disease. Several days, the fever goes away. That red rash appears and disappears in a few hours to a couple days later. And there's no vaccine or treatment except for reduction in the fever, which is the palliative care, taking Advil or taking acetaminophen.
Is that parvovirus? That's not the same that a dog gets, huh?
Yeah.
No,
Same
that's just
family.
wondering. Same family.
Same family virus,
That's
but
part of
yeah, so it's
Vivarium?
yeah, so that's same family of viruses. Sometimes like a family of viruses will have diseases of insects as well as humans. It's really based off of the DNA or RNA
Okay.
and then the shape of the virus is where they get their family names. Viruses are weird. They have very strange naming techniques because they're so difficult to see and what they actually look like. All right. Now we're switching over to something a little bit different. We only got a few slides that are left. So we got warts. It used to be, what did your grandparents tell you that warts were caused from? Frogs. Thank you. I was one. They didn't want me to be the only weird one. You get a frog to pee on you, right? Well, In this case, it's not, it's a papillomavirus, right? So it's going to be a virus that gets into the skin through a minor lesion. So you have some sort of little lesion. Again, it could just be from shaving, right? You end up shaving, you get small little cuts, maybe nothing that even bleeds, anything that you even recognize you have, but they're there at a microscopic level. Viruses, remember, are incredibly small compared to bacteria, so even the smallest little opening can allow it to get in. So they're small tumors, papillomas, where this name comes from. Small tumors consisting of multiple protrusions of tissue covered by the skin or mucous membrane. So we've all seen a wart before. They're basically like a permanent pimple of some sort. Rarely becomes cancerous, but warts can manifest into full-blown cancers, and some of them are going to be sexually transmitted. So this is the same papillomavirus that causes cervical cancers that we now have a vaccine against. Same family of viruses that cause warts. Half the time, this wart's going to disappear on its own, but a lot of people may go to their dermatologist and they can actually have it frozen off or cut off, get rid of it a lot faster. But even if you don't do that, usually within a couple of years, it'll go away. There's more than 50 different types of papillomavirus that infects humans. So again, it's not the same one that causes a wart that causes cervical cancer, but the same family. And much, as sometimes we get these weird little quirks in viruses as well as we do with bacteria. The viruses here can survive on inanimate objects or fomites for a period of time. So this is something that we can actually transfer back and forth in people by just touching inanimate objects. Treatment, removing those abnormal cells, especially if it's starting to change shape. This is why if you do have warts or any sort of other oddities to your skin, your dermatologist usually will tell you, just keep an eye on it. If it starts changing shape or color or something like that, come back and see us. Otherwise, it's just going to sit there and do nothing. But if it is causing a problem or causing some sort of inconvenience to the person, maybe it's in a spot that, it keeps getting open because of movement, if it's on the hands or fingers, then we go in and remove those abnormal cells, basically lance it off and move forward from there. Now we're switching gears. The last 4 slides here are the eukaryotic diseases. So these again are going to be pretty basic, pretty straightforward, nothing that's terribly serious, but just let you know that they exist. Superficial cutaneous mycosis. So anytime we use the word mycosis, it tells us we got some sort of fungal infection happening. Cutaneous, superficial, just basically right underneath the skin surface. And so these are going to be dermatophytes, can invade the hair, nails, keratin of the skin. These are just a class of fungus, dermatophytes. And this is going to involve pretty much every single commercial during a sporting event, especially when John Madden was a little bit younger, tough acting, tenactin, and whatnot, right? You got jock itch, athlete's foot, ringworm, all these type of things that are pretty benign. We have over-the-counter medications now in the form of Lamisil and Lotrimin, things like this. But they're all got different names to them. So they're all based on the location. So tinea, anytime we use the word tinea, that means it's a fungal infection. All right. So we got tinea capitis, which is going to be scalp. You can go through each of these, but essentially it's just telling us, when we write down the progression of the disease, or we're writing down the diagnosis, we'll put down the actual name based on where it's located on the body. But it could be the same exact fungus that's causing that. It just gets a different name based on its location. Signs and symptoms, usually none except for itching. It could have some bad odor to it, depending on where it's located at, and a rash of some sort that can actually spread from that initial spot. Get patchy areas of hair loss if it does get into the scalp. So people that have severe fungal infections that get into the scalp or into the follicles, it can actually cause their hair to fall out. So they'll end up having patchiness, which would be pretty terrible. People that get fungal infections on their toes usually changes the color, usually thickens up the nail of some sort, where it actually is looking pretty bad. And sometimes it'll actually completely separate the nail away from the nail bed and they'll lose the nail completely, which can be a good thing sometimes because then you actually can start out fresh again. You don't have that infection. you also can get these rashes that basically start forming that basically fine papules, right? Just very small spots.
If that were to happen, like on the nail bed,
Mhm.
would that happen to like just one nail, or would it happen to?
It would just happen to the one that's infected, but it can spread from nail to nail, depending on,
See it with a lot of elderly patients.
Yeah, especially
Oh my
elderly
gosh.
patients.
Really good.
All right, so we got, just a whole list of different fungal funguses that can cause this. So just knowing dermatophytes is enough. I'm not going to ask you to know all the individual ones because we don't focus much on fungal infections in this class as we do the bacteria and viruses. But knowing dermatophytes are going to be the important grouping of fungal infections that cause it. Here we can see this is a pretty serious case. Probably a small child there. Where we have not only the infection of the nail beds, but we also have it spreading up, down to the first knuckle there, where we got the open wounds and things, probably from scratching and itching it constantly. Pathogenesis, it's just going to spread from person to person. Once it establishes, it causes the immune system to get agitated. And that's where that redness and those rashes are going to come from. If it doesn't cause the immune system to get agitated, then you just end up with yellowing of the nail, or the hair follicles end up getting expanding and causing the hair root to actually fall out, which then causes the hair fall out. But at the same time, pretty straightforward of clearing it. We're just going to take in patient age, as Shannon said, as well as virulence of the mold, so we have to identify it, especially if it's actually gotten so bad that it's driven them into the clinic. Now, if you just go in and say, oh, what's this rash right here? We're not going to go trying to diagnose it. We'll probably just do over-the-counter treatments first. Maybe a prescription that's needed, but we're not going to go into full diagnosis unless we think it's something pretty severe. And then we'll worry about the virulence of the mold. Moisture is important. So why is it called jock itch? Well, because it ends up around the groin area. Why there? Well, it's dark, it's humid, it's got the right conditions that fungus loves to grow in those areas, as well as feet. People that get athlete's foot, whatnot. This is because they're wearing the same hot, sweaty socks. They may not change. They may not take a shower after they go to the gym or work out. Always problematic for growth of the molds. And so pay attention to cleanliness, drying out, wearing powders, anything that basically dries up the skin, trying to pull away that moisture is always important to try and prevent it, especially if you have a full-blown infection. All right, other fungal infections, just right here, we got just 2 more slides. We got the yeast, and we've talked about this one before, right? Candida albicans, we'll be seeing it several times, especially when we get to genital urinary tract infections. This is just part of our normal skin, microbiota. But if it gets able to get into those deep layers, then we end up having major problems here. We have no idea why the yeast acts differently from person to person. So that's what that third point there is saying, that there's no precise cause for infection, so we don't really quite understand it. Certain molds can also cause cutaneous mycosis. So even though mycosis is usually funguses and this is a yeast, it can look very much like a fungal infection, even though it's a different type of organism. So here is a list of all the ones we went through. So it's always good to start with your learning objectives for the chapter, as well as summaries, before you go in and start trying to learn material on your own. Here you got every single one we went through from the beginning on Tuesday, acne, all the way to Lyme disease for the bacteria, varicella to warts for the viral, and then superficial fungal, as well as yeast infections that can be on the skin. If you have any questions, let me know. Otherwise, we'll see you all on Thursday to take the